So, good morning to all of you. We will discuss the robotic fundoplication. This is one of the surgery which is considered as the better outcome compared to laparoscopy if you will perform robotically. Because of three division, posterior mediastinum esophageal mobilization is easy, and the crural approximation is also considered to be easy. So, we will see how to do fundoplication, then also we will see how to do Heller's myotomy and how to do hiatus hernia repair. Nissen has performed the fundoplication first, and according to statistical data which is published, that Nissen has started this surgery for the hiatus hernia first, but now the main purpose of this surgery what we perform is for GERD. However, hiatus hernia is also indication, but maximum number of the fundoplication now we perform for gastroesophageal reflux disease, which is defined as the failure of anti-reflux barrier allowing abnormal reflux to enter into the esophagus, and it creates the esophagitis, ulceration, inflammation and pain. In US and Europe, 44% of the population they describe the symptom of GERD. In India it is less, but in Europe due to stress, lifestyle, alcohol, smoking, 44% of the population they describe the symptom. But in that 44%, only the 10 to 15% have the characteristic GERD, rest of them just they have hyperacidity. And men appear to be have more complication because of the testosterone and some other unknown factor. Female has less symptom of GERD. 10 to 50% of the patient require long term treatment for the GERD. Now, what are the symptoms? The first symptom is heartburn, that is retroesternal burning and regurgitation. If alone only heartburn and regurgitation is there, then it is not necessary to think about the surgery. You can do the medical management with the proton pump inhibitor. But if the patient has chest pain and respiratory symptom due to aspiration and pneumonia, then surgery should be seriously think about. And after that you will start proper investigation. The first investigation, first stage is that you will do a step 1 endoscopy and barium shallow. These are the first line of investigation, and if these two will give you some indication about the surgery, then before surgery esophageal transit plus minus manometry and pH monitoring must be done. Now, LA classification is very important in endoscopy, that is Los Angeles classification. In LA classification, there are 4 grades of GERD. In grade 1, one or more mucosal break will be there, but their diameter is less than 5 mm, and they doesn't extend beyond the top of the tube mucosal fold. So, in LA grade A, this is the first grade of the GERD, you do not need surgery. Most of the patient they will do well with just proton pump inhibitor. We can see this is LA grade A. These are the mucosal breaks, and there is no severe esophagitis, and they are not extending beyond of the two mucosal fold, they are in between the two mucosal folds. So, these are the LA grade esophagitis, and these patients need long term medical management and change in the lifestyle. Smoking, alcohol, these things should be stopped, and they will manage by medical management. Now, LA grade B. In LA grade B, mucosal breaks are more than 5 mm. It may be 10 mm, 15 mm, but they also doesn't extend beyond the top of two mucosal fold. LA grade B also can be managed by medical management, but the problem is after stopping the medical management, 80% of those patients within 1 year of drug withdrawal they have recurrence, and in that situation long term treatment is required and abstinence from alcohol, smoking and streak is must, otherwise recurrence rate is very high. However, this is also not a indication of the surgery, because it does not go beyond the top of the tube mucosal fold. You can see very long mucosal breaks. This is healthy mucosa and this is broken mucosa. So, it is a long, bigger than 5 mm. Now, LA grade C, of course, it will be bigger than 5 mm, but how the difference between B and C is that it is continuous between the top of 2 or more mucosal fold, but less than 75% of the circumference is affected. So, in these cases we can see these are the very long and it is extending beyond the top of the 2 mucosal fold, and these are LA grade C. This is healthy mucosa, this is healthy mucosa and this is broken mucosa due to ulceration, and these patients need surgery. They are seldom cured by the medical management and they have the very high recurrence rate. So, surgery is warranted. Now, LA grade D, here at least 75% of the circumference or more than 75% of the circumference of the esophagus will be involved, and these patients are going to get a severe complication, and sometimes there may be severe stricture or Barrett's esophagus and they need surgery. Without surgery medical treatment will not work. You can see here this is the healthy mucosa and these are the broken mucosa. So, at least 75% or more than 7, this is the only, that much is the only healthy mucosa and this all is, so at least 75% and sometime more than 75% of the mucosa will be ulcerated. So, surgery is indicated. So, first line investigation nowadays is endoscopy, and once endoscopy has warranted, after that surgery is started. So, port position is very important and baseball diamond concept of the port position is applied here also. This is a universal port position for the robotics, and you should take care that remote sensor should be respected, and if the patient is bariatric then you should use 20 centimeter ports. There are two sides of the operating port, one is 12, another is 20. As we know that in robot optical port is your own port and that depend upon, you can use VG port, you can use Hassan port, you can use simple trocar, safety trocar, and half instrument should be in, half instrument should be out. You should telescope always in the middle and manipulation angle should be 60 to 90 degree and the remote sensor should be respected. This is the basic principle of the robotic port position, and telescope will be in the middle and two working instruments should be such a way that 60 to 90 degree angle should be formed. What is we do in fundoplication? In fundoplication, at least 5 centimeter of the intra-abdominal esophagus has to be mobilized. So, it has to be pulled down. Normally, what is the length of the intra-abdominal esophagus? Yes, 3 centimeter, 3 to 5, but sometime you have even 1 centimeter. If it is 1 centimeter, then you have to do cholecystoplasty, means you have to apply endo-GI linear stapler and fire the endo-GI linear stapler at the level of the angle of his, and you have to make a neo-esophagus, means you have to increase the length of the esophagus in the intra-abdominal part, in short esophagus. So, if it is suppose 3 centimeter, then remaining you have to pull it and mobilize the posterior mediastinum, and you have to pull this part of the esophagus inside the abdomen, so that minimum 5 centimeter of intra-abdominal esophagus should be there and minimum 10 centimeter of the fundus also should be mobilized by cutting the upper part of the short gastric, and then you will take a wrap and you will apply. There are many type of fundoplication like Nissen fundoplication, Tupe fundoplication, Dor fundoplication, Thal fundoplication, Rossetti fundoplication. So, Nissen is a complete 360-degree fundoplication. So, when Nissen has started, then it was very popular, but later dysphagia was reported, then partial fundoplication started. But after doing partial fundoplication, recurrence rate was more. So, now again for GERD and hiatus hernia, Nissen fundoplication is gold standard, but you have to make a floppy Nissen. Floppy Nissen means it should be shoe-saw appearance, and you should choose, that is shoe sign, and then at least 10 centimeter of the stomach and 5 centimeter of the esophagus should be mobilized. So, it should be loose, just like the floppy Nissen, it should not be tight. So, this is now the gold standard. And for Heller's myotomy and other partial fundoplication like Dor fundoplication is 180-degree anterior wrap. So, we will see both the fundoplication today, that how to perform, and this is a very successful surgery. However, new surgeries are also there, that is the links procedure, in which we use earth magnet to wrap around, or TIF is transoral incisionless fundoplication, but these are still in the experimental age, and the gold standard is the still surgical fundoplication. This is the port position for fundoplication. This is the telescope, will be supraumbilical. So, suppose this is umbilicus, then supraumbilicus, and then we will take one right hypochondrium, one left hypochondrium, one assistant port also can be used here. So, basically if you will see the port position, docking should be from the head side, robot will come from the head side and assistant will be sitting in here. One port right hypochondrium, one port left hypochondrium, and telescope is 5 centimeter above the umbilicus, that is the supraumbilical, and this is the position of the room setup and the position of the optical team. So, this is how docking will be performed. Sometime you may do the side docking also, but even if you side docking, then also this is the side docking. You can see the head of the patient is here and robot is on the side of the patient, but even if you do side docking, port will be same. Only difference is that head end of the patient will be free for anesthetist. In the previous here, anesthetist has the problem, anesthetist has to sit here. Anesthetist after intubation, he cannot be here, because this area will be occupied by the robot. So, anesthetist has to go here, and he has to bend and then come to check the patient or adjust the tube or do the some other maneuver. But in side docking you have the advantage that anesthetist will be in the usual position, and this is also preferred, and patient head should be 15-degree head up position, and patient you can see head is up, and whenever you perform this way, always take care that in robotic after docking patient position cannot be changed. So, we should change the patient position, do the diagnostic, put the Nathanson lever retractor is must, and this is there are two type of Nathanson lever retractor. This is the table held Nathanson lever retractor. Here you have a clamp, and this clamp you will attach in the table. So, this is just you will make it, and this clamp you can attach with the patient table. So, I will show you how to do that. You will lose it. Here I am making clamp lagao jaldi se, and then we are attaching it here. In this table also we can attach thoda sa idhar, it is attached, and then tightening. Or tight karo. So, it is tightened and it is fixed now, it will not go anywhere, it is fixed. After that you will make it here and then lift it up, isko loose karo, and then it move up, and then you can adjust it at this level and it will be tightened. After that you have a three lever retractor. This is large size, this is medium, and this is a small, depending upon the age of the patient and size of the liver and fatty liver also you will select it. After that this has a clamp, you will bring it here and then you insert it, and remember always this convex part should be towards the diaphragm. So what you will do, you will put one epigastric port just left to the GP sternum, and then insert it perpendicular and then rotate in clockwise direction. So initially you will insert perpendicular, like suppose this is your port, 5 mm port left to GP sternum. After that always go insert perpendicular, and then just you have to rotate clockwise essay, and as soon as you rotate it will lift it and it will be towards this end will be towards the diaphragm, and then this attachment will be here and you will fix it here and then tight it. And once you tight it, you can see here that suppose this is the lever, then lever will be protected, or loose karo. So now we can see here, so it is tightened and now lever will be sitting over that. So just for your vision I am putting like this, lever will be sitting on that and it won't come out, and this end will be protected, so there will be no injury. So this is very good, and it has been demonstrated first by Nissen. So it is called Nissen lever retractor, and this is available in different if you will buy from stores then it will cost you 3 lakh rupees, but if you will buy from Om Surgical it will cost you only 30,000-40,000 rupees. So better is to buy Indian, because it doesn't have any special rocket science, it is just a rod and just a stand. Now if you don't have it, you can use this Nissen. This is called handheld retractor. Here if you will see this screw, if you will lose it, it will become straight, and after that it can be introduced with the 5 mm port or 10 mm. It is available in 2 sizes, fan retractor or 5 mm लेके आओ, उसको रख दो ऐसे ही. So this is 10 mm as well as 5 mm, and when we will rotate this, it will become like a snake. So some people also they say that it is a snake retractor like this, and then it can lift the lever. But this can never be introduced with the epigastric port. It has to go 24 centimeter away from the right anterior axillary line, then only it can lift, because elevation angle, if it is acute, it cannot lift. So elevation angle should be 15 degree, then only it will lift. This is available in the 5 mm also. So initially you will make it loose, after that it becomes straight, then you take the 5 mm port and it will go easily like this. Here it enters, and once it is entered, then again we will tight it and it will bend and become a snake shape. So it is now done, and now it will retract the lever. Now when you have to take it out, then don't take it out directly with the 5 mm port. This is important, because if you will take it out this way, it is stuck and it break. So what you have to do, you have to pull everything together, cannula also. If you will try to take it out, there is a wire here, see this wire, and it has been reported that it is stuck with the wire and wire break, and these are beads. These are small beads. Beads like the priest, they use beads to take the name of the god, same way. It has beads, and all beads will drop in the abdomen. It break. So when you remove this retractor, pull everything out like this, and then carefully your nurse will be take this out from the cannula like that. So directly pulling is not allowed, and then it is out. Another is the fan retractor. You have the different type of fan retractors, but fan retractors has a problem that it should be put the net in the front of the fan retractor. There is a stretchable net, because directly putting fan retractor has a problem that if you little bit rotate, it can pierce the liver and the bleeding started. So there is a net available which you can put on the fan retractor. It is just like socks. So that will protect it. And another problem of the fan retractor is that sometimes short gastric or omentum get trapped in between the two fan. Now the problem is if you will close it, it may cut. And other problem, if you pull it, it won't come out with the open fan. So these are the fan retractor. We can see here I am opening, and this is fan retractor. This is 10 mm as well as 5 mm. This is fan retractor, and these fan retractors, some are articulating. So see, it is bending also. So it can articulate and then it can open also. This is closed and this is open. So these fan retractors are very good, but sometime what happened that some tissue, omentum, short gastric get trapped in between this jaw, and now you are in trouble, because if you want to pull it, you cannot pull in the cannula because it is bent. Another problem is if you will straight it also, like I am straightening it, and if it is straight also, then with the open fan it cannot be pulled. And if you close the fan, you have a problem that it can cut the omentum or the part. So this is stuck now. So if I am closing, see, it is cutting the omentum or this. So this should be avoided. These type of a small fan retractor, 3 blade and 5 blade fan retractors are available. So it is up to you. Sometime if you don't have, you may use a stone holding forceps also to retract. And Nathanson lever retractor has advantage that it is attached to the table, hand held, you need one assistant to hold it. Now we will see how to perform the surgery. This is called pars flaccida. Pars flaccida and the membranous part of the falciform ligament. These are the two peritoneum where it is always transparent. It doesn't matter how much BMI of the patient is there, it is always transparent. Pars flaccida is separating the lesser sac from the greater sac, and it is covering anterior to the caudate lobe of the liver. So assistant will pull the stomach caudally. Assistant ऐसे pull करेगा caudally, and assistant port is at the level of umbilicus in the left anterior axillary line. And once he will pull it, you can see there is a stretch over the pars flaccida, because without pulling peritoneum will not get a stretch. So you can see traction is in this direction and the peritoneum is stretched. After that you can open. Some people they start with the angle of his and then go this side, and some people they start from here and go this side. It is same, there is no difference. So you will open and then caudate head. What is this? This is caudate lobe of the liver. As soon as I open, caudate lobe of the liver will be visible. And here what is this? This is right crus. Remember, just below the pars flaccida, below the caudate lobe, there is vena cava. So you should never try to go below the caudate lobe, and don't try to lift the caudate lobe below. What happens sometimes when you are taking a bite on the crust for crural approximation, then accidentally your needle can prick the vena cava. In that case, if the vena cava is pricked, you should not try to suture it, or you should not try to stop it by immediate. You should try to convert to open, because as soon as you convert to open and remove the Nathanson lever retractor, pressure of the caudate lobe and left lobe of the liver will immediately stop the bleeding. But if you will try to not the, this is called preventive and this is called elective conversion. But if you will not do that and you will try to take a heroic attempt to suture or take a bite, then you can stop the bleeding, but you will lose the patient. Why? Because of air embolism. This area is so nearer to the heart, maximum 6 centimeter distance. So, CO2 immediately enter and to do air embolism. Patient doesn't die due to the bleeding, patient will die due to air embolism. In the periphery, if the CO2 enters like from the uterus or myoma or inguinal hernia, then air embolism chances are less, because CO2 is 200 times absorbable than oxygen and 20 times more absorbable than room air. So, in periphery, if CO2 enters, by the time it reaches to heart, it gets absorbed, because it is so much. That is why we are using CO2 for pneumoperitoneum, that air embolism should not happen. But here distance is so nearer that by the time it get absorbed, it will do air embolism. So, it is vena cava should be very seriously taken care of. And now you will open this peritoneum anterior to the esophagus and then go to the angle of his slowly. You can use here, this is the vessel sealer of the Da Vinci, but you can use anything you want. Now, this is the lateral mobilization. This is the crus, here is the esophagus, and this is the lateral mobilization. And slowly, white is right. As we know in laparoscopy, two things is always important, that it is a virtual surgery. So, always remember white is the facial layer. Second thing, always remember that fat belongs to organ. If you have a fat, that means it belongs to esophagus or stomach or rectum or bladder. Like if you are doing hysterectomy, always put fat towards the organ, adrenal fat towards the adrenal. In cases of bladder dissection, fat belongs to bladder. In rectal dissection, fat belongs to rectum. And always white is right. So, we should go in this areolar plane, and slowly you will reach. So, this is the right crus, and this is slowly lateral mobilization. After that, anterior mobilization, and then you go to the other side. So, mostly we should try to do blunt dissection in this area. Now, here this is angle of His, and approximately 10 centimeter of the short gastric you should separate on the left side near the fundus. And after opening this retrogastric tunnel, here this is retrogastric tunnel is formed. This is the stomach, above is esophagus, and this is a greater curvature and short gastric. In the sleeve gastrectomy, we take all the short gastric after just leaving 6 centimeter towards the pylorus, but here you need only 10 centimeter on the upper part of the fundus. And once this retrogastric tunnel is formed, then directly either harmonic or ligature or vessel sealer you can continue at the greater curvature, and these short gastric should be separated. In the sleeve gastrectomy, we want to remain as near as possible to the stomach, and if stomach burns also, we do not care, because it will ultimately cut. But here you should not be burning the stomach, little distance should be maintained, and this short gastric little distance should be maintained, and then you should cut. In sleeve, when you are cutting, we are just touching the stomach. Here touching the stomach should be avoided, and at least 5 millimeter distance from the stomach should be maintained, so that collateral damage will not burn it. Once you reach near the spleen, then you will get some adhesions with the spleen, and this is a spleen, and this is a very vulnerable area of bleeding. This is the most vulnerable area of the bleeding in case of fundoplication, because sometime here varicose is also found, and sometime very difficult. So, you should be careful that parenchyma of the intestine should not be stretched, and you should be careful doing this dissection. Here you will have, and as soon as this adhesion will be finished, after that you will reach to the diaphragm. And now it is reached to the crus. After that, anterior mobilization also will be performed. Dissection of the greater curvature and short gastric is now almost finished. So, again coming to this is the again caudate lobe, this is again right crus, and now this is called posterior mobilization. During posterior mobilization, you have to give the lateral traction, and this is the posterior retroesophageal tunnel, and this is the retroesophageal tunnel you have to make this tunnel, and this tunnel is formed. So, mostly we should try to do blunt dissection. Only if you have some pedicule of the vascular, then only you can use the energy. So, now this is again anterior mobilization. So, what is this? This is crura. Crura is plural and crus is singular. Right crus, left crus, and where both join together is called crura. So, this is the esophagus, this is the right crus, this is the left crus, this is the stomach. So, this is little bit anterior mobilization is also done, and now you will enter into the mediastinum, posterior mediastinum. We should be careful that we should remain as medial as possible. If you will go a lot towards the left side of mediastinal pleura can open, and then pneumothorax can develop. So, we have to be careful that we should remain in this is the esophagus. So, we should remain in the center, we should not go towards one side more. And now, this is pulling this is the crura, this is the esophagus, and little bit mobilization is only required, and assistant is pulling the esophagus caudally. And here if you will see, this is anterior vagus, that is also called left vagus, which is embedded into the esophagus, and this is the posterior vagus. Posterior vagus sometime attached, sometime has a distance, but anterior vagus is mostly embedded, you will not see separately. So, this is vagus should not be damaged, because damaging the vagus create exploratory diarrhea post-operatively. However, within 3 months it regain, it become normal, but vagus should not be cut. And nowadays vagotomy or selective or very selective vagotomy is also an obsolete procedure. So, it is not performed and vagus should be respected. So, slowly you will separate it, and it is pulled down. So, sometime once you reach there, that dissection of there is a fat is also there at the level of GE junction. This fat is also has to be separated. So, now this fat at the GE junction you can separate. This fat is called which fat? This is called which fat? This is called Bell-shaped fat. There is a fat here which has a name. So, it should be separated. So, now we can see here 5 centimeter, 3 to 5 centimeter minimum. It must be more than 3 centimeter. Our very senior surgeon Dr. Palani Velu has written one article that even 3 centimeter of the mobilization of the esophagus is enough. We do not need 5 centimeter, but some literature say that it should be more than 3 centimeter. So, you can measure by either a scale or by open jaw of the grasper, you can measure. A scale is not important. So, this mobilization is very important, and now it is separated. After that, you may use a sling there. Purpose of sling is directly holding the stomach and pulling may be traumatic. So, once the retroesophageal tunnel is formed, then you can put a sling. For the sling you can use rubber tape, cotton tape or umbilical tape, and the assistant will hold the sling and pull it. Why? Our purpose is to make it 5 centimeter. So, this remaining of the esophagus we have to pull and mobilize from mediastinum. So, instead of going into the mediastinum, better is to pull the esophagus in the abdomen, and this is the posterior mobilization. So, this assistant is holding. This is not a robotic instrument, this is a lap grasper, and this grasper assistant is pulling it in this direction, so that you can pull the esophagus in the abdomen, and then you can do safely mobilization. Now you will put a bougie, that is gastric calibration tube. This is called gastric calibration tube, and you have to use 36 French bougie. This is gastric calibration tube. And however, if you will see the literature, many surgeons they do not prefer the gastric calibration tube. They say using gastric calibration tube make the more tightness, because we have false sense of security and we think that gastric calibration tube is there, so they take more tightening. It is not necessary, but some surgeons they prefer. So, this is up to you. 36 French gastric calibration tube you will put it. So, we can see here, this is the gastric calibration tube is coming, and after that this is the tube has come in the stomach, so that you will not make a tight wrap. And now the fundoplication starts. Now, before plication you have to do crural approximation. So, what is this? Esophagus. What is this? Right crus. What is this? Left crus. And this is called crural approximation. You have to approximate the crura. Now, my question is that how many bite you should take to do crural approximation? 3 is also correct answer, 2 is also correct answer, and 1 is also correct answer. It depends upon how big the hiatus hernia is there. But remember, looser is always better than the tighter. When you take a bite and there is no hiatus hernia, then 1 is also enough. So, how to know? At least 5 millimeter gap must be there in between the esophagus and your suture, so that a instrument 5 mm can pass. So, suppose we have that much big hiatus hernia, then 1, 2, 3, 4 also may be required, and no hiatus hernia, 1 is also enough. So, depending upon that, it 5 millimeter gap must be there, and it depends upon how much crural defect is there. So, this is the full thickness bite, and here out to in and in to out. This side be careful that never go below the caudate lobe, remain on the crus, because if your tip of the needle will go it can prick the vena cava. And here which suture you will use? Ethibond. Ethibond XL, that is the best suture, and you can see this is tumble square knot. Here it is sliding with the tumble square knot. So, tumble square knot has the advantage that it will approximate the crus and it will slide its own. You pull it and it is slide, and now you cut it. So, here you can see depending upon, and here you can see that much opening must be there. So, only 1 knot was enough there, you do not need to tie more knot. However, if it is big defect, then you need more knot, and now you will pull the stomach from behind the esophagus, and slowly it should be pulled. You should take care that it should have Su-sign effect, like this comes, and this is Su-sign. Su-sign means just like when you go to the railway station, then poor guys are Su-signing it. So, you should try to Su-sign the stomach over the esophagus. This is very important, and this will give you the idea. This is called Su-sign. That means it is a floppy fundus, and then you pull it, and then slowly this is Su-sign, and then you pull, this is Su-sign. So, means it is if it is not Su-signing, then you should try to mobilize the stomach more. That means something is inhibiting it. So, after that slowly this is Su-sign, and then you slowly pull it from behind, and then you will see that it is a floppy fundus, and then you will take a bite on the stomach full thickness, and then this is you will do the plication. So, basically we say that fundoplication is a collar around the hanger, just like this is the collar and this is the hanger. So, it has to be completely 360-degree wrap, and here it will be suture, and again this is tumble square. You can see it is sliding and straight and sliding, and then you will do it. So, it is important that it should be floppy fundus and it should not be tight. Looser is better than the tighter. In the first bite, only stomach to stomach will be taken. First bite, only stomach to stomach is taken. In the subsequent bite, you can take stomach, esophagus and stomach. Why? Because after first bite, when you leave it, it has to go little cranial. So, if you will take in the bite in the esophagus, in the first bite it will tear, and you can know, you already know that esophagus does not have serosa, it has only muscle, and in second bite when you take, esophagus is very prone to perforate if you take a deep bite. So, only few fibers of the muscle is required, and in the subsequent bite esophagus will be sandwiched in between the two layer of stomach, and this is how you will pull it, and then you will again slide it. This is called tumble square knot. You can see this is a straight and it is sliding, and then this is untumbling. Untumbling means pull the tail end and needle end, this is untumbled. Is it clear? I will take little back. See here. See, this thread is straight, and this is which end? Tail end, and then it is sliding. See, and now once you pull tail and needle opposite to each other, this is called untumbling, and once it is untumbled, it is locked. So, this is very important knot in robotic for tissue which you want under tension. Otherwise, if you will take a C surgeons and go for reverse C, first C will become loose. Am I right? And then it is unlocked. So, this is tumble square knot and it is done. Ethibond suture, again this is the bite here, this is esophagus, this is the second one, and this is the last bite. Again you will take little esophagus muscle and then deep bite in the stomach, and again it is sliding, tumble square, and again locked. So, this is how, this is the last one. Again sliding the tumble square and locking it. So, this is beautiful. Now, you can see, you can measure it, that how much is my distance of plication. This should be more than 5 centimeters. So, now this is over. After that you will remove the gas, you will remove, this is Nathanson lever retractor, you will remove the Nathanson lever retractor. You may irrigate little bit fluid and the gastric perforation can be tested. If you want, endoscopy also you can do postoperatively, means intraoperatively at the end of the procedure. So, this is how fundoplication is performed. Before I switch to the Heller's myotomy and diaphragmatic hernia, is there any question regarding this?
Sorry, sir, tumbling should be done on the left side, but
No, it depends which side is your needle end. Sometime if we want to keep the long limb, if you will pull the tail end, then your needle will cut. So, it depends which side, like when we take a bite right to left, then we have more suture to the left, am I right? But suppose your needle end is short, like you have already taken 2-3 knot, needle end is short, then you want to remove the needle now, then you can pull the tail and then you can slide the needle on only. You got my point? Initially, suppose needle was 20 centimeter and you want that you have to take 2 or 3 bite. Then if you will pull tail end, then tail will be bigger. So, we want to pull needle end and slide tail end. But if you want to remove the needle now and tail is short, then you can slide the tail end also. So, once it is a square knot, then any limb can be straight, but mostly we put left side straight, because our needle end will remain bigger. If you will put the tail side straight, then tail will become bigger and needle will become shorter, but you can slide any side you want. Any other question? Pardon?
If you want to do a partial wrap, we can do the same suture, leave it a little looser in the anterior part.
No, if you are doing two-pay fundoplication,
Yeah.
then you are not, it is not necessary to approximate the fundus to fundus. What you have to do, that you have to suture the fundus with the diaphragm, with the crus. In two-pay fundoplication, because fundus to fundus will not be wrapped, so if you will just take a wrap and you will fix with the right crus and left crus, then it does not go back. You got my point? Even if you put loose and if you have taken a suture anterior to esophagus, it will become Nissen. So, in the toupee fundoplication, fundus to fundus, it is a 270-degree wrap, and the fundus to fundus is never approximated anteriorly. Fundus is pushed with the crus, suture of the fundus with the crus. And in the door fundoplication, which we will see, which is now in the Heller's myotomy, then that is 180-degree anterior wrap. So, how to do? You will mobilize the esophagus, put it anterior to the myotomy, and you will protect it. It has many advantages. One advantage is that if the mucosa is perforated also, it will protect it. Another, it will not allow crust to get approximated. Another, that it will keep the splitted muscle of the esophagus apart. So, any other question?
Can you do this for asymptomatic hiatus hernia?
No, in hiatus hernia, if it is large hiatus hernia, you should use mesh with the suture. I will show you. This is our next video.
And how far is the cisterna chili and the lymphatic vessels from where we are working?
That is far away. For that, don't worry, it will not come in that way. So, now we are seeing the another video. This is the Heller's myotomy.
So, the last question I had is, if you perforate the pleura by accident, I believe the pneumoperitoneum will enter the chest.
Yes, that will be a problem, that as soon as mediastinal pleura, it is left side of mediastinal pleura will open, then the left side of chest start collapsing.
You stop and
No, it is not necessary to stop. You continue the surgery, only thing that put a chest tube, because your patient is intubated
at the end of the surgery.
at the end of the surgery. Because our patient is intubated, so patient will be still able to ventilate due to positive pressure, and our pressure is only 15 millimeter mercury, so it won't obstruct your surgery. But at the end of the surgery, you must put a chest tube. So, this is now we will see, here is the peritoneum over the esophagus is cutting, and you will again, this is started from angle of his. So, this patient has achalasia, and this is the Heller's myotomy. So, this bell-shaped fat that is near the GE junction is again removed, and then you will separate it. So, now this is the anterior mobilization, slowly, and this is, we can see, approximately 7 to 9 centimeter, some people 7, some to 9 centimeter of the esophagus should be mobilized in Heller's myotomy. Your opening of the crus, opening of the this pars flaccida, and rest of the entire surgery will be just like fundoplication. There is no difference. Only thing is that you have to go more in the posterior mediastinum, especially in the short esophagus. And now we have to make this is the bougie, and you have to make a retroesophageal tunnel. And after that, we have to completely split minimum 2 to 3 centimeter over the circular muscle and 4 to 5 centimeter over the longitudinal muscle of the esophagus. You should put a gauge piece ready. Why? If it is split, you cannot use current. So, with the gauge piece, if bleeding happens, then you should press by the gauge piece. So, if you have a little adhesion, vagus should not be cut. So, vagus should be retracted. If little adhesion, you can use this circular muscle fibers, you can use the hook. But anterior traction is important, and first you hook, then look, then cook. So, yes, this is the vagus. And this is the mucosa is exposed, as you can see. So, in robotic we do not have a tactile feedback. So, it is very important that we should look for the visual interpretation and first hook, look and then cook. Do not activate in open circuit. Now, this is the mediastinal part of the esophagus, which is slowly splitting. So, this is the mucosa and this is the muscle which is splitting.
So, we try not to open the mucosa.
Of course, mucosa should never be opened, but remember, if mucosa open, it is not a indication of conversion and it does not affect the outcome of the surgery. You can just suture and you can put the fibrin glue. Now, this is again going down. This is very important that gastroesophageal junction part must be cut, because if you will not split this part, then there will be no benefit, and any residual muscle fiber also should be inspected.
How do you see the criminal level Christy at this point?
You can do the endoscopy, upper GI endoscopy, to find out. You want lymph nodes to see?
I mean the criminal level at this point.
Venous always at this point, venous will be the vagus will be embedded, and venous will be vision. There is some time here you can see sometime you may have to do the, if suppose you want to see the blood circulation, you can use the ICG also if you want. So, this is the gastroesophageal junction part which is cut and this is over. So, this must be 2 to 3 centimeter of the gastroesophageal junction part which will be splitted.
Now, how to make sure we are completely cutting the muscle but remaining outside the mucosa?
That you have to do by visual interpretation, and sometime if you do endoscopy, residual fibers will be visible if it is not cut completely by transillumination. You can see the light transillumination that will show you. So, but that is only by visual interpretation, because the mucosa will bulge out. Once the muscle is cut, mucosa will bulge out. So, this is over. Now, here we can see that little bit short gastric will be mobilized, little bit only at the level of the fundus, because we have to take a door fundoplication, anterior 180-degree wrap. Maximum 5 centimeter, you do not need a lot of stomach, and this is over. After that, it is ready for taking a door. Now, in the door fundoplication, first bite should be on the stomach, on the we are taking on left side. After that, you take a bite on the left crus, this is left crus, first bite on the stomach, then left crus, deep bite, and then muscle of the splitted left esophagus. So, this is the esophagus and this is the muscle. Here is the mucosa, mucosa should not be taken, only muscle of the esophagus which you have splitted, and then you suture either silk or ethibond. So, this is suturing on the left side. What is this? Mucosa. Am I right? What is this? A splitted muscle. So, first bite was taken on the stomach, crus and muscle. Now, second and third bite you will take stomach and muscle. So, this is stomach and muscle. What is the advantage? This is mucosa, that stomach will not join again, it will not come again, and it will be a type of fundoplication. So, this is the left side suturing. After that, right side you will again take a bite on the posterior wall of the stomach, and then again muscle and the right crus. This is the muscle of the esophagus. which you have splitted, and the right crust, and it will be sutured. So, this is important. Again, this is stomach, this is muscle, and this is right crust, deep right crust you have to go. This is the right crust. An assistant will keep it pulled here. This is the crust. This is the right crust. An assistant will keep it anteriorly pulled and tie the knot. And in the subsequent second or third bite, only stomach and the crust. So, this is a anterior fundoplication, where it is 180-degree anterior wrap and surgery over. You can see this entire esophagus is covered by stomach, and now this is finally endoscopy. And you will find out if there is any stricture. Stricture will be find out by endoscopy, and now it's over. So, this is endoscopy. This is the endoscope, and this is no any stricture.
You don't do anything with the right cross and
No, right crust is sutured with the stomach. Yes, right suture is more important, because left side there is no traction. More traction is on right side, because you are bringing it, so it has a tendency to go back to the left. Now, one very question is asked, that what happens if it get perforated? So, perforation of esophagus and outcome of Heller's myotomy. There is a big study performed in which they say that esophageal perforation is common during the surgery, and it does not affect the outcome of the fundoplication. Iatrogenic esophageal perforation, if you will see, mucosal perforation has no influence on final treatment outcome. So, if you will see these literatures, there is no one very accidental perforation during laparoscopic Heller's is infrequent and impossible to predict on the ground of preoperative therapy or surgeon's personal experience. Even the experienced surgeon, they sometimes nick the mucosa, and despite a longer surgical procedure and hospital, outcome is much as same as patient undergoing uneventful myotomy. So, it does not affect the outcome. This is the PubMed again published that after laparoscopic Heller's myotomy, if the treated successfully, endoscopic stent also, or you can use suturing. So, there is no problem if you will perforate, but it must be treated. Again, these all literature, laparoscopic repair of perforation after Heller's myotomy. Again, all of them they say that we have sometime we over treat. So, we should not be just take a suture. This is very important, because we always follow SAGE's guideline. So, it is saying, does intraoperative perforation impact outcome of Heller's myotomy? You will see no. Esophageal perforation may occur, but do not seem to impact surgical outcome by ensuring adequate myotomy distal to the injury and accompanied with primary suture repair of perforation and door fundoplication. We have avoided complication. Why? Because once you do door, it is covering the mucosa. Only thing is that you should keep the patient nil orally, and post operatively you must go gastrographin test before starting the any oral intake. So, this is sometime happen, and in some of the reported cases you can see these are the incidence of the perforation. So, approximately 5.8%, this is not a less number, they get the perforation. So, it is important that intraoperatively you should recognize it by methylene blue test or endoscopy. In case of perforation, just with 30 Vicryl suture it, surgeons not, and if it is possible, put the fibrin glue.
Can I, when I'm doing my completion endoscope at the end, if I discover that I have a PEF, a clip can do?
Endoscopic clips are not very effective on esophagus. Endoscopic clips are good in stomach, and because you are doing intraoperative endoscopy, so better is to suture laparoscopically. Laparoscopically, why you want to suture a clip endoscopic?
I'm just saying, Prof, I missed the PEF during the scope. Now I'm doing a completion before they wake the patient up, and I find that, hey, I missed the PEF.
You can do, but in that situation, better is to use a stent.
Plus plastic stent.
Yes, you know, even if post-operatively you will recognize, suppose you missed it and post-operatively you stent, then there is a mega esophageal stent.
Stent with the ICD? No.
No, mega esophageal stent, if you will put it, this is called mega esophageal stent. This, and this you can put in the endoscopically, and then what it does? It will, see here, it will, suppose it will, you put it, it keep the lower esophageal sphincter open, and it doesn't allow the intraesophageal pressure of the lower esophagus increase. Then it will automatically perforation will heal. So this is how you can use these stent. Endoscopically it can be introduced, but most of the time by the endoscopy or even by laparoscopically you can recognize and you can suture. I will show you one case where we have perforated. That was laparoscopy. This is Heller's Myotomy. This is a young man, and problem of this is that he has taken the botulinum injection, and you know that is also a treatment. So I will just show you. This is the Heller's Myotomy. This is a young man, and see, this is after doing botulinum injection was taken. So this is mobilization. This is a infant feeding tube, and see, during this a splitting, this area was a lot of fibrosis was there. So we have used harmonic. This is the right side is the Maryland, left side is a grasper, and slowly splitting, and then splitting. This is the gauge piece. If oozing has started, you will push the gauge piece. Now I will show you. This is harmonic was used little bit, because this area was very adherent, not splitting at all, and it was difficult. So harmonic was used, but Teflon jaw of harmonic was kept towards the esophagus and vibrating jaw towards the up, and it is splitting. And here again this is the lower part, splitting. This is mucosa. This is splitting. It is popping up. Can you see that?
Yeah.
As soon as you will split, this mucosa will pop up. Splitting. This is the fat at the level of gastroesophageal junction, which is cut out with the ligature. Now you will see here is the perforation. ये already perforate हो गया. This is, here is the perforation, but still we are not stopping. Two perforation was there. Look at this, one perforation here, one perforation here. This is perforation. What we did, if you will see here, this, can you see the suture? See carefully. Here. And put one suture here and putting interseed over that. Here is a suture and putting interseed over that before doing the suturing. That's all. And interseed will also protect. Now this is stomach, this is crus and then muscle.
So what is interseed? Is a mesh or a?
Interseed is a reoxygenated cellulose which is a protective and it is anti-adhesive also. It is used a lot by gynecologists. No, Surgicel will stop bleeding. Surgicel is basically only for hemostasis and interseed is a adhesive barrier. So yes, so I will show you.
So it can prevent leak.
It will prevent adhesion of the mucosa. So interseed is a product from Johnson and Johnson and it is very good. It is a oxidized regenerated cellulose and it is a adhesion barrier and this is very good. We use it for a small bowel adhesion, chronic pelvic pain and it get absorbed within 2 weeks. Adhesiolysis.
2 weeks.
Yes. So within 2 weeks it get absorbed. So advantage is that in this perforation area it will cover also and it will not allow the stomach to get adhered. So in case of perforation, careful identification and suturing is required. Now we will see how to perform the hiatus hernia. Hiatus hernia, here we can see this is the barium swallow and we can see that this patient has a large hiatus hernia. So this is the again pars flaccida and you will start separating over the pars flaccida. This is the caudate lobe of the liver, this is the crus. Now you can see there is a large hiatus hernia where stomach, omentum all is herniating into the chest. So in this situation first step is to mobilize and bring all the structure in the abdomen. Peritoneum over the sac of the peritoneum over also should be opened and this crus should be also nicely separated. So this is important. After that assistant will keep it pulled. Now the question is that once you have mobilized all, then problem is that if you will directly suture, it will get cut through and it may get again herniate and strangulate into the chest. So after mobilizing it all around the esophagus, same like fundoplication, this is the anterior vagus nerve, here we can see that also should be protected and this is the anterior mobilization, it is done and now this is lateral mobilization on the left side. So we can see entire stomach is herniated into the chest and these are the short gastric near the greater curvature which is mobilized. So all the mobilization anterior, posterior, lateral will be same like how you do in the fundoplication. So once
That includes the two crust with epicon together.
yes, you will do that, but once it is mobilized,
Okay.
because without mobilization and without pulling the content in back in the abdomen, we cannot close. So it is all mobilized, posterior, anterior, this all is mobilized and now it will be pulled down. This is crus. So it is mobilized and now it is over. So this is the posteriorly you have to be careful about the aorta, because 4 centimeter below the esophagus you have the thoracic aorta, that also. Now this is a sling and this sling will be introduced posteriorly and the traction will be given so that all the esophageal area should come in the abdomen. Assistant will keep it pulled, this traction is required and then it will be taken and you can tie a knot also if you are using infant feeding tube and it will be pulled inside the abdomen. After that further mobilization will be easy. I am sorry. After that further mobilization will be easy. So this is further mobilization. Assistant here is the esophagus. Assistant is giving anterolateral traction for posterior mobilization. So, all around mobilization is complete. This is the traction given on the esophagus and this is posterior mobilization. This mobilization is also the same as you do in fundoplication, but because it has a hiatus hernia, so you have to be careful that you should not injure the mediastinal pleura and you should not injure the aorta, and you should do it very meticulous dissection because entire fundus is in the chest. Now, you will use a mesh and put the mesh over the crus and then suture with the mesh. This is suturing with the mesh is required. Why? This is the hiatus hernia. If you will directly suture, it will cut through. With the mesh, if you will suture, it will reinforce. Just like in bariatric sleeve gastrectomy also, we use seam guard. Seam guard is a absorbable reinforcement material in sleeve in between the staples. So, here also similarly, this is a mesh and then this is the left crus, this is the right crus. So, take a bite through the mesh here, and once you will take a bite through the mesh and through the diaphragm, then it will be more reinforced. So, you can see here that this is the bite taken and this is again crus and the mesh, both together will be sutured and then tie the knot. So, this is the again proline, this is a proline barb suture because you cannot use absorbables. So, proline barb sutures are also available, that is very good for even ventral hernia. In the IPOM plus you can use it and then it is sutured. Because normal proline has a problem, it has a lot of memory and it can slip back, but this is a proline barb suture. So, you can take a bite and you can see it is approximating. So, this is all around the mesh is used and excess of the mesh will be trimmed out. Once you reach to the crus, excess of the mesh is trimmed out. So, this way large hiatus hernia can be sutured. Sometime if you want, few bite can be taken anterior to the esophagus also, so that it will stop the opening of the hiatus, but here also looser is better than the tighter and you should not suture more than 5 millimeter opening must be there when you are approximating the crus. Pardon?
It is no role to do a partial
Fundoplication. You want that plication will be done or not?
Yeah, because you have that redundant part of the stomach that was the chest. You can't let it to remain in the
No, gastropexy is required. Gastropexy you are saying, that is required. But before that you have to do the crus. And now this is again Nissen, because you know it is not possible only to do crural approximation and leave it, because without plication, without fundoplication it will not work. Because fundoplication, why Nissen has performed for hiatus hernia, a small hiatus hernia treatment is only fundoplication. Because once a wrap will form, it will not migrate into the chest, but crural approximation is important. Here gap was so much that cut through of the muscle was possible, so that is why mesh was used to make your suture stronger. And now this is endoscopy, just to see that there is no
Fundoplication was not done.
No, it was performed. We can see here, this is a part of fundoplication. You see, yes. So, you can see here this is a partial fundoplication where suture will be taken with the diaphragm. Can you see that? So, fundoplication is must. Toupee you can do, even the Nissen also can be performed. There is no necessity of doing complete floppy Nissen, but fundoplication has to be done. Either you do partial or complete depending upon how much mobilized stomach you have, and this is endoscopy. Esophageal perforation is one of the very important complication which you must identify intraoperatively, and it occurs due to the esophageal mobilization, crural dissection or bulge placement, lead to mediastinitis, peritonitis if missed intraoperatively. Dysphagia usually due to overly tight twisted fundoplication, short esophagus or tight crural repair. So, 5 mm gap should be in the crura. Persistent dysphagia may require endoscopic dilatation or redo surgery. Gas bloat syndrome, that is the inability to belch out vomit due to tight wrap. This is normal in first 4 weeks of the postoperative period, and because of the gastric and esophageal edema. But if persist more than 4 weeks, then you have to do the sometime endoscopic dilatation. Recurrent GERD can happen because of loose wrap, not tightening the crura, wrap disruption, slipped fundoplication or incorrect wrap construction. So, this you need to do redo surgery.